Good evening, everybody. It's a pleasure to be among you here in this important session. I'm going to talk about a common area, and that's treatment of hypothyroidism with a particular reference to the preparations used to replace thyroid hormone. And the talk will be about the art of precision and how important is it to have a precise dose replacement and the preparation used to achieve that. These are my disclosures, as you can see there, and my disclaimer is here. And this is the outline of the presentation. So I'll talk about limitations of monitoring of treatment of hypothyroidism with thyroxine, factors that influence dose requirement of thyroxine, and then I'll touch into the management of hypothyroidism, and finally, the clinical need for formulation of thyroxine with tightened specification. And so I'll talk about the new formulation of levothyroxine before I summarize. So it is evident from when we talk about hypothyroidism that the sequence of biochemical events is as such that the first thing to happen is the rise in TSH. And this happens before the fall in free T4. So as the disease progresses, the first thing that happens is TSH rise, at which time the T4 is normal, and that's by definition subclinical hypothyroidism, which I'll talk about. And then the T4 will fall, so that's overt hypothyroidism. And the T3 will be very slow to fall down. So essentially, this implies that to diagnose the hypothyroidism, we need the more sensitive and precise tool would be to measure the TSH. Except in one setting, and that's central hypothyroidism or pituitary-related hypothyroidism, where we should rely on T4 measurement and not TSH. So it's very important to keep that in mind. What are the objectives of therapy? The objectives is obviously to resolve the patient's symptoms and amelioration of any symptoms associated with hypothyroidism, including biological and physiological markers, including the dyslipidemia, the rise in liver and muscle enzymes, the hypertension that can be associated with it. All these associated comorbidities will settle as one treats the hypothyroidism. And then to achieve normalization of TSH and avoid both overtreatment and undertreatment. These are very important. So let's discuss the starting dose. What is the starting dose of thyroxine? The starting dose is generally in healthy people. So here, there's no one size that fits all. So for normal healthy people, we start with 1.6 microgram per kilogram body weight, that's standard dose, or approximately 100 to 150 microgram per day. Pregnant women needs higher dose, and we know that, and I'll talk about that later. Elderly people, smaller dose is needed, and one has to be slower and cautious in the titration, and one has to consider the normal reference age for older people because it's different from the younger people, something that's missed by many of us. Patient with ischemic heart disease, one needs to be cautious, and therefore one will start with a small dose and watch for emergence of any ischemic symptoms, and one has to be slow in their titration. Again, I'll discuss that later. And then we have people who are taking enzyme inducers like phenobarbital, like phenytoin, like rifampicin, and so on and so forth, these will need higher dose of thyroxine because there's a faster breakdown. So these are the usual standard doses. One of the things to highlight here is the fact that thyroxine requirement correlates better with the lean body mass rather than the total body weight. So that's something which is important to bear in mind. And this really was well understood with this elegant study which was done in people who have thyroidectomy. And they looked at the dose that they require after the thyroidectomy. And they found very clearly that the highest dose was in people with a BMI of less than 25, 1.76 microgram per kilogram. And then the overweight people with a weight between 25 to 29.9, they required a lesser dose, 1.47. And then the obese people require a bit of a smaller dose as well, 1.42 microgram per kilogram, indicating that it's not the total body weight that dictates the dosing of thyroxine. And this will brings us to the TSH targets. So thyroxine therapy should aim at lowering of the TSH to a certain level. And that level has been debated. Some will argue that it's less than 2.5 milliliters per liter in adults with primary hypothyroidism. Overtreatment should be avoided, and that's a low TSH because it has adverse sequelae, adverse cardiac sequelae, adverse bone sequelae, so lower BMD, predisposition to osteoporosis, cardiac dysfunction, including palpitations, tachycardia, atrial fibrillation. And then I'll talk about the pregnancy ranges shortly. So when we talk about the normal reference range, it's important to understand that there's no consensus on this. There's, in fact, a considerable controversy as to the appropriate upper limit of normal for TSH. Most laboratories will quote an upper limit of reference range of approximately 4 millunits per liter. However, there's a strong counter-argument there, and that is that the upper limit of normal should be 2.5 millunits per liter. That's the upper limit of normal. And why this counter-argument was presented was because when they looked at young euthyroid volunteers, they found that 95% of them have a serum level of TSH ranging between 0.4 up to 2.5 millunits per liter. And because of this, they argued that the upper limit of normal, given that these young volunteers and the vast majority of them have less than 2.5 of TSH, then that should be the normal reference range. So this is just to clarify why is this debate about the normal range. And then you may say, okay, so is there any happy medium? I would say yes, there is a happy medium, and that is the fact that we aim at a normal reference range, which could be anything between 0.4 up to 4. If the patient is having a TSH of 2 or 1.5, that's very good. If the patient settled on TSH of 3, is fine. However, if the patient has TSH of, let's say, 3, but they're still having symptoms, or they're concerned about other aspects, tiredness, lack of energy, that the weight is still an issue, then we can push the dose to aim at a TSH of less than 2.5. And that's really a reasonable approach to management of these patients. Thyroxine is given in a daily dose, half an hour to 1 hour before breakfast, and is given with water. Some patients take thyroxine at bedtime, at least 2 hours after the last meal, although ideally it should be longer. So one would recommend that if the patient is going to take thyroxine during daytime or at bedtime, then they should leave it, they should take it at least 3 hours after the last ingestion of food or drink. So 3 hours would be a reasonable thing, up to 4 hours, or in the morning, half an hour to 1 hour before the first meal of the day. What matters is how the proximity to the food ingestion and not the time of the day. So that's very important to understand. And there's a big meta-analysis which showed that there's no difference in the effectiveness of the morning versus the bedtime dose when it comes to TSH measurement, as long as obviously the bedtime dose is given 3 to 4 hours after the last meal. In some studies, serum TSH concentration was lower and less variable with the fasting administration. So there's a more precise TSH control when you take thyroxine before breakfast. And they demonstrated that the value was 1.06 milliliters per deciliter. If you take it with breakfast, then the value will rise up to 2.9, from 1.06 up to 2.9, because obviously that breakfast will interfere with the absorption of thyroxine. And for people who are taking it at bedtime, the TSH was 2.2 milliliters per deciliter. Again, suggesting that the ideal time of taking thyroxine will be before breakfast, half an hour to 1 hour. Neonates need to have a more rapid replacement of thyroxine, which is very important for brain developments and other aspects of physiological well-being. And the elderly and patients with coronary heart disease, one has to be very careful and not to push the dose very quickly and to start with a small dose. So these are the general principles in the elderly, those with coronary heart disease and with severe long-existing hypothyroidism. So the initial monitoring after replacement is generally anything between 4 to 6 weeks. Symptoms tend to improve, so we have to reassure the patient that they are going to start feeling better after within the first 2 weeks. It's not days, so we'll ask the patient, don't expect it within a few days, but up to 2 weeks, and then you will start to see gradual improvement. However, in patients with severe hypothyroidism, it takes time for full equilibrium at the level of the cell to see complete resolution of symptoms. So to reach that full equilibrium at the cellular level, that will take several months. And it's important again to remember that the steady state TSH, so here I'm talking about steady state, I'm not talking about normal TSH. Steady state are generally achieved after about 6 weeks of any dose that's being given. So the impact of any dosing on TSH, if you want to see it at its full-blown effect, then you're going to see it at about 6 weeks. It's also very important to acknowledge that the TSH is the first thing to change. The free T4 is the first thing to change, so it rises up, and then we're going to see a fall in TSH. So the fall in TSH lags behind the rise in free T4. So when it comes to the monitoring and the parameters used, we use TSH as the parameter for replacement therapy with an agreed reference range. That reference range is different for pregnant women. It's different for the elderly population. We monitor every 4 to 6 weeks after initiation of treatment. But once the patient is stable and their euthyroid and everything is fine, then there's no necessity whatsoever for frequent monitoring, and we do the TSH once every 6 months to 1 year. That's more than adequate, except if there's any change in the circumstances. And the dose adjustment is done by the magnitude of anything between 12.5 to 25 microgram per day. It's important to acknowledge that there are some patients with poor adherence to treatment and who have frequent forgetfulness. And there are studies which were done with a weekly preparation, with a weekly dosing. So patient take the total dose of the week in one go. And that may be, although that has not been the evidence for that is limited, but obviously there are studies in Italy and elsewhere which show that weekly dosing works. So those who have a problem with the adherence, maybe problem one can really consider that approach of therapy. The other approach which I do for my patients, and I share with you my personal perspective, is I'll ask a patient to take the full supply of the week and keep them in a container, and from that container they take their daily dosing. So from a weekly dose, they take every day a weekly dose, and at the end of the week, for argument's sake, the end of the week is Friday. Then on Friday, if there are any leftovers, they can take them together. Leftover means that they really forgot to take certain doses. Or if their week ends up on Sunday, then on Sunday they can check the container. If there's any leftovers, they take them all together. So that's really maybe a practical tip to ensure that the dose is given in full. Factors that influence the dosing requirement of thyroxine. There are certain populations in whom one has to be particularly careful: pregnancy, elderly people, comorbid conditions, ischemic heart disease, concomitant medication, and food intake. So in pregnancy, during pregnancy, there are two approaches for people who already have diagnosed with hypothyroidism in the past. So one can have the approach of checking the TSH very early in pregnancy, as early as possible in the first few weeks of pregnancy. The other approach is to do a preemptive increase in thyroxine dosing, and one will tell the patient increase it by about 15% if they had previous Hashimoto thyroiditis, or by about 30% if they have previous thyroidectomy. So how to do 15% is by taking 8 doses per week instead of 7 doses. And how to do 30% increase by taking 9 doses of thyroxine during the week instead of 7 doses. So 2 days of the week, they will take double the dose. And that's what's called the preemptive management of hypothyroidism in pregnancy. And then obviously one has to monitor TSH every 4 to 6 weeks and titrate the dose accordingly. So when it comes to the reference ranges, we have trimester-based reference ranges. In the first trimester, 0.1 to to 0.1 up to 2.5. And the second trimester 0.2 to 3, third trimester 0.3 to 3. And one has to monitor the TSH approximately every 4 weeks during the first half of pregnancy in order to adjust the dose of thyroxine based on the pregnancy-specific reference range. When it comes to hypothyroidism in the heart, it's important to appreciate that there are issues related to hypothyroidism, including hypertension, diastolic hypertension, diastolic dysfunction, dyslipidemia, prolongation of the QT interval, elevation of the CK muscle enzyme, where statin can be hazardous there, obviously, and coagulopathy. So if in the setting of ischemic heart disease, one has to be careful because thyroxine increases the inotropic and chronotropic effect on the heart and can cause exacerbation of angina. So we start with a very small dose, 12.5 to 25 microgram per day. We increase the dose again slowly every 6 weeks by 12.5 to 25 microgram. And we explain to the patient that should they observe any worsening of their angina, they should report to us and suspend the treatment. And they should report immediately. It's important that if the cardiac symptoms became an obstacle to normalization of thyroxine, it's important to treat the ischemic heart disease medically or surgically, and then to aim at correction of TSH to a normal level. And subclinical hypothyroidism, obviously subclinical hypothyroidism is normal free T4 and elevated TSH. It has no specific symptoms, and antibodies are usually positive. So what we do when the TSH is between 5 to 10, that depends on the symptoms. If the patient is symptomatic and have high thyroid peroxidase antibodies or evidence of atherosclerotic cardiovascular disease or heart failure, then the case can be made to treat these patients. However, in the setting of TSH of above 10, there's evidence that as the TSH exceeds that cutoff point, there's an increase in the risk of heart failure, cardiovascular mortality, and treatment with thyroxine is mandated. Is there a need for new formulations of thyroxine with precise and tightened specification? The answer is yes. And why is that? Because if we look at the data of replacement therapy, and from different studies, we can see very clearly that that in all these studies, patients, about 40% of the patients are not at goal, either above TSH, above the goal, or below the goal, either over-replaced or under-replaced, about 40% of them. And this is really a significant number. So with the TSH of more than 4, we can see very clearly that there's also an increase in the risk of cardiovascular disease, arrhythmias, and fractures. And when one overtreats, again, TSH of less than 0.03, there's an increased risk of cardiovascular disease, arrhythmias, and fracture. And therefore, it is extremely important to aim at the TSH at the recommended target level. What is the effect of undertreatment in non-pregnant adult patients? Dyslipidemia, atherosclerotic, cardiovascular disease, congestive heart failure, and these are more serious in the elderly population. In pregnancy, there are fetal sequelae and maternal sequelae if one does not correct the dose. For maternal sequelae, including miscarriages, stillbirth, hypertension, preeclampsia, postpartum hemorrhage, subfertility, and fetal sequelae will include the low birth weight, preterm delivery, and irreversible cognitive dysfunction. So, as I pointed out, we need a precise dose in the elderly small dose and slow titration. That's very important. In the elderly, the reference range is different, so it will be higher than the standard adult reference range, anything up to 4 to 6 million per liter. And as a matter of fact, elderly patients more than 75, one should accept a level up to 7 million per liter as the normal reference range for this population. We start with the lower dose in order to avoid cardiac arrhythmias, angina, and myocardial infarction in people with a pre-existing cardiac condition. As I pointed out, in the more elderly population, we aim at a TSH up to 7.5 as an acceptable reference range. Many health authorities recommend tighten their potency specification with thyroxine in order to increase the stability of the formulation of thyroxine and prolong the half-life for at least 18 months. So what does the Euthrox provide to us? Euthrox provide wide ranges of thyroxine with active ingredient between 25 up to 200 microgram per day and a shelf life of 3 years. So that's very important. With patent-protected formulation with improved stability, including mannitol, citric acid, and other stabilizers. So for the Euthrox, there are 2 excipients which were changed recently, where the mannitol was added as a replacement for lactulose to enhance stability, and that's very important. And anhydrous citric acid was added to enhance stability as well. And as a result, the Euthrox formulation is more stable with extended shelf life up to 3 years. But the active ingredients remain the same. And this really increases stability, and precise dosing is very important, more so in the special population, including the pregnant women, including thyroid cancer. We need a spot-on replacement dose in the elderly involved with poor adherence and in children. And if we look at the bioavailability of the Euthrox new formulation, we can see that it's the bioavailability is identical to the standard Euthrox formulation. And as you can see there, the curves are overlapping when T4 was measured. However, longer half-life, longer shelf life, and more stable compound during storing when it's stored. So to summarize, ladies and gentlemen, Euthrox new formulation is a once daily dose with the same broad range of strengths as the old formulation, ranging between 50 up to 250 micrograms per day. Euthrox new formulation tablets have the same appearance as the old formulation, and patient can take Euthrox new formulation under the same conditions as the old formulation in terms of fasting and so on and so forth. And with that note, I conclude my presentation. Thank you for your attention, and I'll be happy to address any questions that you may have. Thank you.